My name is Sherene Loy. I'm a medical oncologist at the Peter Macallum Cancer Centre in Melbourne, Australia. So I don't know what time it is, but it all looks pretty great here. So I'd like to introduce our first discussant. It's Dr. Reshma Mahtani from the Miami Cancer Institute. And I'd like to thank all the poster presenters for being here so early to take questions. And she will discuss posters 1, 2, 4, and 6. Thank you.
Good morning, everyone. Thank you for the opportunity to review these important posters, and congratulations to the authors on their work. Just waiting for the slides to... Okay, here are my disclosures. The availability of biomarkers to predict response is a cornerstone of advancing personalized treatment in breast cancer. This morning, I will review 4 studies that explore key questions about predictors of chemotherapy response and highlight how these insights may guide future tailored treatment strategies. We'll start with the sub-study, the 9906 of the GUICAM trial by Dr. Martin et al., and provide some background on the SET2/3 genomic test. This is a novel biomarker, as shown in red, that measures endocrine-dependent gene expression while notably excluding genes related to tumor cell proliferation, and is adjusted for prognostic factors including stage and molecular subtype based on 4 genes. This test can be performed on a core biopsy or a surgical resection specimen. As detailed here, there are multiple validations of the prognostic ability of the SET index in prior retrospective analyses of several prospective studies, which have shown high SET index is associated with better outcomes in treated patients with stage 2 to 3 breast cancer. In terms of predictive data, the assay was previously shown in a retrospective analysis to identify patients who benefit from dose-dense chemotherapy in the CALGB 9741 trial. The current sub-study tested the SET index in the GUICAM 9906 trial, which, as a reminder, evaluated the effectiveness of adding weekly paclitaxel to FEC in patients with lymph node positive, hormone receptor positive, HER2 negative breast cancer, and demonstrated an approximate 6% improvement in disease-free survival with the addition of the taxane. The current translational cohort represents around half of the entire population, but the SET evaluation was performed in 88% of the hormone receptor positive HER2 negative samples provided and was isolated from FFPE samples with 16% with a low SET index. As shown here, the SET index was able to predict benefit from weekly paclitaxel, as shown on the left, and there was no significant interaction between the index and overall survival. Nevertheless, the SET index did show a clinically relevant overall survival predictive value in FEC-treated patients. So how can we put this data into context? Here are some considerations and clinical applicability. Several randomized trials have been conducted to investigate the role of adding taxanes to anthracyclines, demonstrating improvements in disease-free survival, and some studies also in overall survival. As such, for node-positive patients, it's standard practice to include taxane therapy. So how can we consider these data? This is the second clinical data set that demonstrates predictive ability of the assay and confirms the generally accepted premise that hormonally driven tumors derive benefit from chemotherapy. This is a retrospective analysis which requires validation in prospective clinical trials, ideally. In clinical practice, the relevant question is who needs anthracycline versus non-anthracycline chemo? Validation of this biomarker in this setting would be of interest. Prior studies have demonstrated the ease of use and reproducibility of the assay, and it could provide complementary information to currently utilized genomic assays, with some data existing that the SET index provides independent and additive information in that setting. Moving on to the second abstract by Dr. Lay, PDX allows deconvolution of chemotherapy response. As we know, standard treatment for stage 2 to 3 triple-negative breast cancer is polychemotherapy based on the Keynote 522 trial. But the question remains, do all patients need all these therapies, with the understanding that group-level data may not apply to individual patients? This figure shows the current conundrums of cancer treatment, including restricted beneficiaries, tumor heterogeneity, drug resistance, as well as tumor metastasis and recurrence, and shows the versatile functions of PDX in developing therapeutics against cancer. In this study, the authors investigated 50 PDX models of triple-negative breast cancer treated with single-agent docetaxel, carboplatin, and the combination. Here is shown a representation of the tumor quantitative drug responses at day 28 versus day 0, and on the right, the clinical equivalents. Note these are described as human equivalent combinations which were administered. In only 4 out of the 42 PDXs, combination chemo showed statistically enhanced benefit over single agent, and these are shown in the pink boxes, suggesting combination chemo is ineffective versus the best single agent. Questions that arise when looking at this data include, would multiple doses of the combination or single agents produce different responses than a single dose? And also, will the estimation of tumor response translate to humans? I'm sorry? Okay, well, we can look at that in the discussion as we have a discussion further. So the approach that was taken to generate chemotherapy predictors was to generate chemotherapy predictors leveraging these PDX data sets with external triple-negative data sets, which are summarized at the top. And for each treatment type, a clinical data set was selected as an independent test data to evaluate fully trained model performance. And most importantly, and what distinguishes this methodology from others, is the ability to select protein-informed RNA markers for the platinum and taxane combination predictors, since both RNA and protein data were available for training. And you see those results on the bottom in purple. So questions that arise include how the weighting was done in the model, how the algorithm was derived, evaluation of the fully trained model and multiple external independent patient data sets is commendable, although the number of samples overall is small. The multiomics model did show a predictive value with an ROC of 0.85, which would be considered of clinical interest. It's certainly unique to have a multiomic predictive marker, and understanding the individual contribution of response to multi-agent chemotherapy may offer the opportunity to de-escalate treatment for some patients with early-stage triple-negative breast cancer, with these trials ongoing. Additionally, these data are undergoing further validation in clinical cohorts. More broadly speaking, it would be of interest to know if these findings could be useful for chemotherapy prediction in other cancers and even to other subtypes of breast cancer. Moving on to the MammaPrint blueprint predicts pathologic response to neoadjuvant chemo in the hormone receptor positive, HER2 negative early breast cancer patients enrolled in FLEX. We know that pathologic complete response rates to neoadjuvant chemo in these patients are lower than in other subtypes, and significant heterogeneity in response is noted. The NBreast and I-SPY2 trials have demonstrated the utility of MammaPrint and Blueprint in predicting PCR in these patients. The high-risk MammaPrint index is separated further into high 1 and high 2, with minus 5.7 being the cut point. Prior data sets summarized here have shown higher PCR rates to neoadjuvant chemo and MammaPrint high 2 tumors. The FLEX database is a prospective longitudinal observational real-world trial enrolling early breast cancer patients with MammaPrint and Blueprint on their primary tumor as part of standard of care treatment and has enrolled a large number of patients to date. The current cohort includes 457 patients who had hormone receptor positive, HER2 negative breast cancer and were treated with neoadjuvant chemo with available PCR and/or RCB data. The pathologic response, as defined as PCR plus RCB1, was the primary endpoint, where the authors intended to look at the association between MammaPrint index and PR. Virtually all the high 1 tumors were luminal B, and the high 2 tumors were split with slight enrichment for the basal tumors. Higher stage and grade cancers were significantly more likely to be MammaPrint high risk. The study results are shown here. PR rates significantly were higher in high 2 basal and high 2 luminal B tumors compared to high 1 luminal B. Note the hashed part of the bar represents patients who achieved RCB1 with neoadjuvant chemo, and although PR rates were mostly driven by PCR rates, I would consider the roughly 4 to 6% of patients who were able to achieve RCB1 as clinically meaningful to help with downstaging. There was no significant difference in PCR rates by nodal status. On multivariate analysis, MammaPrint high 2 index was associated with PR with an odds ratio of 3.3, not 12, as was reported initially in the abstract, which is an important correction. When the model was adjusted for chemotherapy regimen and further refined for grade, the treatment effect did change. So as we put this data into context, an important question is PCR an important endpoint in hormone receptor positive, HER2 negative early breast cancer? And there's some data to suggest that perhaps it may be in MammaPrint high tumors. Here you see results, long-term results of individual level PCR data with 3-year follow-up from I-SPY, and among 361 patients that were MammaPrint high risk, 3-year EFS was 96% in those who achieved a PCR versus 81% in those who did not achieve a PCR. It's very important to note that there are no current long-term outcomes available on these neoadjuvant patients in this current data set, but there are plans to report that information as the FLEX data matures. Additionally, there are some accumulating data that point to the fact that MammaPrint high 2 tumors may have a distinct biology, including a heightened immune state, which is also being tested in an ongoing SWOG study, as well as a differential benefit to anthracyclines in the neoadjuvant and adjuvant setting. Of course, this data regarding anthracyclines is not randomized data, but is certainly building up some support to this hypothesis, which requires further testing. And then finally, the fourth poster, the HER2 DX, a correlative analysis from the Cleopatra trial. The Cleopatra trial, as a reminder, demonstrated improvements in progression-free and overall survival with the addition of pertuzumab to taxane and trastuzumab therapy as first-line treatment for HER2-positive metastatic breast cancer patients. Notably, at the landmark analysis at 3 years, there were still patients doing very well, with the challenge being how to identify these patients with no clear biomarker available. The HER2-DX assay is a commercially available assay based on 27 genes that recapitulate the main biologic features of HER2-positive breast cancer into one of 4 gene signatures. Importantly, this information is integrated with clinical factors such as tumor and nodal stage to provide 3 key scores: a long-term prognosis or risk score, a PCR likelihood score, and the ERBB2 MRN expression score. HER2-DX has undergone considerable validation in the early stage setting that could be helpful in clarifying prognosis and likelihood of PCR. The HER2-DX ERBB score is designed to measure the relative abundance of ERBB2 mRNA associated with the protein. It's reported as low, medium, and high. The ability to predict HER2 status has been validated in prior series. And in real-world series that have been reported previously, a high HER2-DX score has been shown to be associated with better overall survival and PFS compared to a low score following THP and also following second-line TDM1 monotherapy. The current study assessed the HER2-DX ERBB mRNA score's ability to predict long-term outcome in the Cleopatra trial. The assay was performed with a high success rate on approximately half of all the tumors from the THP arm and was shown to be associated with PFS and OS. Notably, about 14% of tumors were classified as HER2-DX low, and these patients had inferior PFS and OS to first-line THP. I'd like to call to your attention a couple of other posters that are being presented at this meeting that are building upon this story regarding identifying a biomarker in this setting and similarly showed worse outcomes in patients with lower ERBB2 copy number. Looking ahead, as we know, the standard of care may change soon in the first-line setting based on the results of the DB09 study, which has yet to be reported. If TDXD, either alone or in combination with pertuzumab, outperforms our current standard, how will quality of life compare? Additionally, a biomarker to identify patients, HER2-positive metastatic patients who may achieve excellent long-term outcomes with THP would enable more tailored first-line therapy decisions, particularly given the differing profiles, the toxicity profiles of these drugs. So in summary, these studies all represent important steps forward in the road to personalized therapy, and I leave for you the top-line results and possible future directions as we put this data into context. I'd like to acknowledge Dr. Mark Pegram, Dr. Neal Iyengar, and Dr. Sarah Tolaney for their assistance in this presentation. Thank you.
Thank you. I'd like to invite the poster presenters up on the stage, please. So that's Dr. Miguel, Dr. Lay, Dr. O'Shaughnessy, and Dr. Cortés. If you have any questions, please come to the microphone, introduce yourself, and there is also the Q&A option on your app. So questions, panel is now open for questions. Dr. Thompson.
Thank you for a wonderful presentation, fantastic posters. Question for Dr. O'Shaughnessy, if I may. The SWOG 2206 trial is using Durva to target those mammaprint high patients that you have shown very convincingly, patients who need a little more assistance. What do you think is likely to be the outcome of that trial? A very unfair question.
You know, the I-SPY trial that Lajos did with the team, of course, that led to this 2206 trial was weekly paclitaxel followed by AC, you know, the control arm, and then it was the investigational arm was weekly paclitaxel with olaparib, and they weren't germline BRCA patients exclusively with the durvalumab added, followed by the AC. And there was this, in this high 2 population, the PAF-CR rate was like a triple negative breast cancer, over 60%. And then the control arm was around 10 to 15%. But then in the high 1 population, the PAF-CR rate was 10%, even if you were adding the olaparib and the durvalumab, you know, versus the paclitaxel followed by AC. No benefit at all, you know, from adding the DNA damaging agent and the checkpoint inhibitor. The issue with that is, you know, how do you sort out which one it was? And this is in the high 2 HR positive, the HR positive population. So, you know, because it could be both. And the 2206 is just looking at the checkpoint inhibitor hypothesis. It's not looking at the DNA damaging hypothesis. But, you know, we get the doxorubicin cyclophosphamide, you know, are in there, just not the platinum. So I think, though, that the high 2 population, you know, is enriched for that immune signature. The I-SPY group has come up with the immune signature called the imprint, and that high 2 is enriched for the imprint signature. It also is enriched for the HRD. That's where the HRD signatures live as well. You know, so I mean, I think we have to kind of do one thing at a time to really, really demonstrate what the addition is. But I would predict it's going to be a positive trial.
And we know, of course, the 2 checkpoint studies, excuse me, last year in HR positive were positive for increase in PCR, 7FL, which is currently in press in Nature Medicine, and the Keynote 756. So I think absolutely right. And so imprint is actually in the high 2 score.
Yes, that's my understanding. And there are other experts here, but it's more targeted towards the high 2 than the high 1 is my understanding. And somebody correct me if I'm wrong on that, who's here.
Okay. Thank you. Do you have any other questions? Oh, let me just have a look. Yeah, one question that's related to that is, So would you change your practice to give neoadjuvant chemotherapy to the mammaprint high?
So the issue of preoperative chemotherapy for the HR positive, HER2 negative patients remains a work in progress. I would say really who really benefits from it. I will say that in general, the higher the risk patient, both from an anatomical, just tumor burden, stage 3 or a very high risk stage 2 with clinically nodes positive, and the higher the risk, the biology, the more virulent it is, and the high 2 would play into that. The more interested I am is in getting going on the systemic therapy, as long as I can. Patients tend to have more extensive surgery these days for these higher risk cancers, and by the time they get their surgery and sometimes even reconstruction on top of that, they're 2 months down the road. So mainly from the point of view of wanting to get going on the systemic therapy earlier, I think but that's true probably with the mammaprint high risk in general, high 1 and high 2, in terms of the neoadjuvant question, whereas if it's lower, then I'm going to want to just go to surgery first, and find out what the entire biology of the cancer is, if they're, surgical candidates.
Sure, thank you. I might ask Dr. Martin, how do you see the future of the SET index? Would you use it in your practice now? I mean, I think the data is quite compelling now.
Well, I would like, but I think we need more studies. We need more evidence before using the test. Dr. Mahtani mentioned that we ideally should run a prospective trial. This is true, but unfortunately, I'm afraid this is not possible today because academic is not in position of running costly trials, prospective trials. So I think that the way to proceed is to achieve level 1B through 2 different retrospective studies in which the biomarker is tested positively and prospectively, And we have these trials, and there are other trials, other adjuvant trials, in which we could obtain more information regarding the value of the test, but at the present moment, I think it is a little early.
Okay.
Thank you.
All right. I guess, Dr. Lay, you had a very fascinating poster. Congratulations.
Thank you.
How much do you think a PDX can recapitulate the immune response, I guess, is my question for you. Obviously not well at all, but
Yes,
what's the contribution to your results?
Yes, sure. I mean, definitely the PDXs are devoid of an immune system, as everybody knows that. But I think there could still be tumor intrinsic properties there that's very interesting to look at. They may show up as immune related pathways, but they could be more tumor intrinsic, and those things we can still model. And I think we did pretty well already with responses to both carboplatin and taxanes, despite the PDXs not having an immune system. So, the degree to which not having an immune system affects our predictions, that's still to be determined.
Thank you. And then Dr. Cortés, next steps for your assay. I mean, I think I'd like to congratulate everyone. Everyone's assays are very well defined, pre-specified, good cutoffs. So these are very well developed biomarkers, and I think, it seems we need a lot of evidence to incorporate them into daily practice. So Dr. Cortés, what's the next steps for your work?
So, first of all, I think that we have plenty of data with HER2-DX in the early breast cancer setting, and I think, and this some of the comments I will discuss afterwards in my discussion in the TNBC-DX part, I think that we have more evidence than what we had before with some of the platforms we are using today in the clinical practice in the estrogen receptor field. So, for example, we are running now Oncotype and MammaPrint, among others, based on phase 2 studies basically, and afterwards we had the phase 3 studies, but we didn't wait to have the prospective phase 3 trials to run or to use these platforms in the clinical practice. And we have many more data in the early breast cancer setting, the HER2-positive field with HER2-DX, than what we had with the other platforms in the ER-positive. And today we are discussing if we should use HER2-DX in the clinical practice or not. So that's my first comment. The second comment is about the poster I presented. I think that it's obvious that HER2-DX also is a terrific tool to optimize or to help us to decide who are the patients that are going to benefit more or less from anti-HER2-based therapies. If the question is if this test is ready to be used in the clinical practice in the metastatic setting, I think this is my opinion, not yet. But I think that we have to stop doing clinical trials as we are doing today. For example, next year, hopefully, we'll see many data about trastuzumab deruxtecan in the early breast cancer setting, Destiny Breast 9, Destiny Breast 5, probably also in the metastatic setting, Destiny Breast 11 and 5 in the early and 9 in the metastatic. Should we treat all patients with TDXD if these trials are positive? My answer is no. The point is how to decide who are the patients who will really need TDXD in the adjuvant setting or who really need TDXD in the metastatic setting. And this is one of the platforms that could help us to decide who are those patients. So, in conclusion, I think that we have great data with the biomarkers, but if we do not realize that we need to incorporate them into the randomized phase 3 studies, I think that we are going to have small steps and we have to do larger steps. So that's why I think that we are ready to use them in the early, but we have to use them in the clinical trials in the metastatic today.
Yeah, I think it's very important that the academia pushes these biomarkers for incorporation into the large registration trials. Obviously, that's very difficult for us to do, isn't it? Questions, Dr. Simmons?
Yes, a general question really to anybody in the panel, and I think it came up a little bit earlier with Dr. Martin, but it feels like there's a real existential challenge for precision oncology, in particular the biomarkers, with respect to prospective randomized trials. And the Hayes-Simon-Paik paper is now a very long time ago. And I wonder whether there's in the setting where treatments can't be reasonably randomized anymore, let's say triple-negative breast cancer, chemo versus no chemo. That's never going to happen, as was pointed out earlier. Is there a white paper approach that is now, that we need to revisit in terms of like what principles are we going to move forward? Because as I listen to all of the great biomarkers of this meeting and in this session, I keep thinking almost none of them will ever be feasibly evaluated for their intended use in a randomized prospective trial. So why would we, can we find a criteria where we say, this is where this would be possible, reasonable, and expected, and this is the other situation where what would be the levels of evidence are? Do we still have it right with the level 1B, or is there a new way of looking at this?
100%. Next question, please. Oh, Dr.
I just want to mention, I think what's been done with HER2-DX is a really good example. It's going back to multiple prospective randomized trials and applying the biomarker with a statistical analysis plan and really showing over and over in multiple of these studies and now a meta-analysis that really can predict who's really at high risk in the curative HER2-positive setting and who's at low risk. So I think that's a really, really good example. I just want to mention with regard to the high 1, high 2 question, there's been enough hypothesis generating data now from retrospective analysis of the FLEX trial, for example. You have to build that data first. Then you can go to the ABC trials, for example. So there'll be a collaboration with NSABP, who has the tissues on the ABC, which was 6 cycles of docetaxel cyclophosphamide versus an ACT or TAC regimen, isolating the question of the anthracycline, where the anthracycline came back a little. It was not non-inferior. I mean, it was a small benefit from the anthracycline, very small, but who are those patients? So now we're going to be able to do what HER2-DX has done around that question of anthracycline. And I think that's really a powerful way to go if you can find those data sets. There's not a ton of them, but if you can find those prospective randomized trials where you then can go and apply your biomarker, very, very prospectively with a good statistical plan, I think that's very persuasive.
Yes, I mean, I agree. I think retrospective analysis of trials is very persuasive. Very final questions very quickly, and then I'll have the next panel, have the next discussants, please.
Actually, just a clarification. So the strategy was 4 cycles of combination docetaxel carboplatin versus 4 cycles of single agent. So it was a direct comparison.
Okay, thank you. Thank you for the clarification. So thank you, congratulations. Thank you for an excellent discussion. Thank you. Okay, so for the next posters, 3, 7, 9, and 10, it's my great pleasure to invite Dr. Cortés to the stage. Thank you.
So thanks very much, Sherene. Thank you very much, dear folks, dear colleagues. Thanks very much also the scientific committee, basically Dr. Kaklamani, Dr. Arteaga, for inviting me to discuss these 5 abstracts. To be very honest, I want to tell you something before. When I looked at the posters, there was 4 of them, basic science, translational research. I didn't understand anything of 2 of them, nothing at all. So I have had to study so much about that, you can imagine. So I want to tell you something. I'm going to discuss this from a clinical perspective. So I beg your pardon if you expect for me to do something very science-based. I will not. I will not. I'm a physician, a medical oncologist, so I would like to make discussions about how to integrate this in the clinical practice. Apologize if you expect something more. For the questions, ask the authors of the posters, please. So, nevertheless, I don't like to have papers, but I have some of them to read because, again, Kivioli, imagine. So these are my disclosures. We have been talking about mechanisms of resistance to anti-HER2 therapies for the last 20 years. Mechanisms of resistance against TKIs, against antibody-drug conjugates, and or monoclonal antibodies. But it's true that more and more we have studied the heterogeneity as another potential mechanism of resistance, and maybe I will make some comments in a minute. And maybe for those patients whose tumors do have heterogeneity for HER2, we should add systemic chemotherapy, and maybe for a selected number of patients without this heterogeneity, anti-HER2-based therapies only could be a good approach. So let me start with the first abstract, Kabraji and colleagues. I will review these 3 abstracts together because they are related to HER2 mechanisms of resistance, and we'll make comments about all these 3 abstracts together. So which are the key results of this good poster? The first one, that there are genes associated with protein synthesis, LAS2, and lysosomal function, HEXB, which are upregulated in HER2-off and HER2-low tumors. HER2-off are tumors that were HER2 positive before and became HER2 negative afterwards. The second conclusion of the study is that LAS2 overexpressing tumor cells are found in both HER2-off residual disease, which were originated in HER2-on tumors. And this expression negatively correlates with ERBB2 in all tumors. And finally, this is a very interesting figure. You can see here that when you knock down ERBB2 in the HER2 positive cells, the first day you have an increase in LAS2, but when we have a complete blockade, you have a decrease in the LAS2. So that's something that appears quickly and disappears afterwards. Just for you to know, the extracellular vesicles are related to aggressiveness, to aggressive behaviors of the tumors. And it is clear that when you have oxidative stress, HEXB is or has an important component to explain the release of these extracellular vesicles. But there are data, at least in hepatocellular carcinoma, that when you have high expression of HEXB, you have worst prognosis. On the other hand, LAS2 is a protein which is involved in protein synthesis and metabolism, which is in the mitochondria. There are very controversial data in terms of prognosis. Again, in colorectal cancer, we have data showing that when you have high expression of LAS2, these tumors do have better prognosis, and the other way around. When you have B cells with high levels of LAS2, in colorectal cancer, you have better prognosis. So again, controversial data. I will make some comments together afterwards. Second abstract, CD155, and as a potential treatment mechanism of treatment resistant in HER2-positive breast cancer. So some comments here. First, it correlates in a negative way with the HER2 expression in HER2-positive tumor cells. Second, is associated with worst prognosis in HER2-positive. And third, when you silence the CD155, there is a reduced in the tumor proliferation. And what is very important, very interesting at least, is that the expression of this gene is or might affect the immune infiltration, which could be a mechanism of immune evasion. Again, I will comment this abstract in a minute. The third abstract, 23 patients, and they explore the spatial omics and T-DXd resistant. 23 patients. Some of them HER2 positive. Some of them HER2 low. And very, very variety of tumor samples. So an important heterogeneity of this group of patients. As expected, the higher the HER2 score was, more T-DXd response. Non-responsive tumors show decrease in immune infiltration and activation. And something interesting, that when we looked, for example, the brain and the bone metastases, they looked at shared mechanisms. One of them, for example, increased in fibronectin, which blocks the immune system. Another one, dendritic cells maintaining the exhausted T cell needs. So some of the aspects are shared by different metastatic sites. So let's go to discuss these three abstracts. So first, HER2 overexpressing tumors are completely different to HER2 low tumors. So in my opinion, I think that we should not combine in one study both groups of tumors. You can see here, DESTINY-Breast03 and DESTINY-Breast04, the activity of T-DXd was much, much different across HER2 positive compared with HER2 low. Overall response rate 80% or 50-55% respectively. Now, do immune markers play a role in the clinical practice if we use T-DXd? I don't know, but I don't think that a single biomarker will play any role. Two comments here. The first one, let's go to DESTINY-Breast03. How many patients did have primary resistance to T-DXd? 1%. Do we think that this is CD155 related? Could be, but I think it's unlikely. DAISY study, HER2 positive, HER2 low, HER2 zero. Look at the activation of cytotoxic lymphocytes. First, it did not change after the use of T-DXd, and there was not correlation between sensitive tumors and resistant tumors. So the microenvironment is too complex, in my opinion, and it's difficult to be explained by single markers. The group of LAs developed HER2-DS, we have been discussing before, and look at these beautiful papers. So Pamela and CLGB 40601. What they looked is that when we explore different signatures, 11 signatures, immune signatures, basically based on the B cell related, this could be even much better than looking at TILs. These HER2-DX signature are formed by 4 different signatures: the immune signature, proliferation, luminal, and HER2 signature. And the tumor microenvironment is also very dynamic. Let's go to, for example, to the PD-L1. PD-L1 is very easy to understand mechanism of activation of resistance to the immune system or sensitivity. Atezolizumab, pembrolizumab approved in the metastatic setting only if PD-L1 positive. However, when we combine these drugs with antibody drug conjugates, it works exactly the same regardless of the PD-L1 expression. Why? Because maybe there's a lot of plasticity. Maybe with some drugs, we might optimize, we can decrease or increase different biomarkers. This is something we have observed in the early breast cancer setting. Look at in Keynote 522. The activity was the same regardless the expression of PD-L1. And there the data with atezolizumab. When you give atezolizumab, after just one cycle, 2/3 of the tumors which were PD-L1 negative became PD-L1 positive. So again, it's a very complex environment and it is very dynamic. In my opinion, difficult to be explained by single biomarkers. And also, we said before, the heterogeneity of HER2. There are data by Otto Meyer, the Christine, showing that when we give anti-HER2 therapies alone to patients whose tumors do have heterogeneity, pathological complete remission is 0%, and the other way around. So in my opinion, this is the ideal setting to explore all these biomarkers, to see if there's real correlation in the clinical practice or not. Let's go to the calcium channel blockers and efficacy to antibody-drug conjugates, a very interesting abstract that came from the clinical observation. There were some data showing that CCBs might increase the activity of sacituzumab govitecan. Key results from this paper. CCBs improve TROP2 antibody-drug conjugate sensitivity in PDX models. And it does not affect the body weight. Second, abnormal TROP2 localization contribute to resistance. You can see here that sensitive tumors, the TROP2 is into the membrane. In the resistant tumors, TROP2 is in the cytoplasma. And third, high levels of cytoplasmic calcium in sacituzumab govitecan resistant. That could be important because it could increase Paxin-2, which is a protein involved in Kivioli stabilization. And this relates to the internalization of the TROP2. So if you have Paxin-2, you might internalize the TROP2 and it disappears from the membrane. So this is something that has been explored previously in patients. We have data coming from Boston showing that mutations in TROP2 might lead to a decrease in the expression of TROP2 into the membrane, and this is a secondary mechanism of resistance. We should explore this, where in the clinical practice, we have Ascent and TROPic-02, exploring the role of sacituzumab, triple negative, ER positive. How did those patients who take the blockers behave? Better or worse? That's something that could be very well observed. Is it Paxin-2 mediated? What about the TROP2 staining? Which is very clear that it should not be implemented in the clinic. We have the experience of metformin. Many retrospective data show that maybe if you take metformin, you could have better outcomes. The Canadian folks did a randomized phase 3 study with 3,700 patients, stage 1, stage 3, ER positive, triple negative, and HER2. No benefit at all. So in my opinion, the CCBs could increase the activity, but it should be explored prospectively. Finally, Drs. Tecklin and Fox did do a great analysis about TNBC-DX in 2 groups of patients, 2 different studies. One of them, carboplatin docetaxel, 280 patients, and the other one, docetaxel, carboplatin, and pembrolizumab, both studies without anthracyclines. Key results. First one, TILS and TNBC-DX PCR score does not correlate perfectly. There is a moderate correlation. Second, in the multivariate analysis, including the treatment, both TILS and TNBC-DX PCR score were independently predictive of PCR. And look at this data. In those tumors with 30 or more TILs, with a TNBC-DX high for PCR, 90 to 92%, without anthracyclines. So, what is TNBC-DX? It has 4 components. Again, an immune signature, not an immune alone biomarker, and proliferation signature together with the tumor size and the nodal staging. It was developed in 3 large clinical trials. It has been validated in 2 large clinical studies. Miguel Martin presented at ESMO this year beautiful data, not only about the PCR component of the platform, but also, which in my opinion is even more important, the prognosis. This platform might help us to understand the prognosis of these tumors. And look at the data here. If the platform was good for prognosis, no metastasis. If these patients did have a bad prognostic platform, TNBC-DX, look at the prognosis of these patients. So what do we have to do? We should explore this in the large phase 3 studies, in Keynote, in Jeopard, those that are going to be presented. Because maybe if we have a patient with a high PCR and a very good prognosis, why not to skip anthracyclines? If we don't do it, we'll continue using anthracyclines. Leukemia, cardiotoxicity, if we have to do it, let's do it. But are we sure that we need it? As I said before, we have been using Oncotype, Mamaprint, Endopredict, Prosigna with with retrospective phase 2 studies. Now we have the MINDAC, we have the TAILORx, we have the responder, we have now evidence 1B. Do we need more data to implement HER2-DX in the clinical practice? And maybe, why not to start thinking about TNBC-DX also? I leave it there. So, just to finish, how can we optimize clinical trial designs? You have a biomarker, or 2 biomarkers, or 3 biomarkers, PCR 80%. It's great for these 80% of patients, but what happened for the 20% of patients? Or what happened if you do not have a biomarker, but you have a great response? How to move forward? One, again, as I said before, I didn't say before. Next slide. Now, as I said before, in my opinion, we have to optimize. Breast cancer is not a single biomarker-based disease. It's a pathway activation disease. Two more slides and I finish. Okay, I will tell you. First, I was showing the Fergeni strategy, how to maybe the best biomarker is the tumor itself. So we should move forward doing something like the Fergeni strategy plus plus HER2-DX, something like that. And this math, like me. So now, well, these are my 3 take-home messages. Next slide, I don't know if there is someone there. Now, leave there. So, great biomarkers here that are very, very interesting in the preclinical models, but it should be explored in the patient data, in my opinion. Immune signatures, such as TNBC-DX, HER2-DX, and others, are much more attractive to be integrated in the clinical practice. This is my opinion. Finally, strategy-based clinical trials combined with biomarkers should be designed to optimize patient care. The last slide, I don't know if I will be able to show, is just to thank you very much, many of my colleagues that in some way helped me to do this presentation. Thank you very much to you all. Thank you.
Thank you. I'd like to invite the poster presenters to the stage, please. My name's here didn't match with yours, but I've got a Dr. Das, Dr. Strickland, a Dr. Kurisetty, and a Dr. Lowe. Could you please come up? And if you have questions, could you please go to the microphone and introduce yourself, or on the app. I might start off with a question to Dr. Cortés or Dr. Strickland. Do we think we can develop some sort of algorithm to identify the patients that will respond? I mean, I agree that it's not going to be one biomarker, but multiple biomarkers can now, with the advent of AI, presumably can form some sort of algorithm to identify all that might respond. Would you not agree?
Yeah, I think that's the key, right? In TNBC, we need clearly biomarkers that predict response to anthracycline, because we have now convincing data that hopefully for some patients we can move away from that. Right now, the vast majority of patients get immunotherapy as well, but what we need in the curative intent setting is obviously a biomarker that predicts who does and does not benefit, because it may very well be a minority of patients.
Yes. And it was quite compelling, the 90% with the both biomarkers, right? But if you have one or the other, presumably the discordant patients will also benefit, presumably, right? So that could be something to be, some sort of algorithm. Yeah. Any questions? We have one on the chat related to Dr. Luo. Thank you for your presentation. What do you think the mechanism is for the effect of the calcium channel blockers? And do you think this will just be specific to TROP2 ADCs or other ADCs?
For now, it's specific to TROP2 ADC, and we haven't do other experience to test whether it's useful in other ADC. Thank you.
And what do you think, how do you think it works, the mechanism?
How does it work?
Okay. Mechanically, excessive intellectual calcium activate PKC and PACS-iron2, leading to the increased capillary-mediated endocytosis. This results in a defective membrane, defective plasma membrane location of TROP2, contributing to the TROP2 ADC resistance. Thank you.
Yeah, that's very important. It seems that the intracellular calcium might activate this paxin-2, which is involved in the KBOLI internalization. So I think that it's an amazing observation because this could enhance potentially the activity of antibody conjugates, but it has to be explored prospectively. But I think that at least going back to not only to Arsen and TROPiCS-02, maybe to many others ADC trials, to who are the patients, or how did the patients who received BBCs behave compared with the other ones? I think it's very easy to be done. It could be very interesting.
Dr. Das, were your samples all metastatic samples in your treatment, your pre or
Correct.
the, yes?
Yes.
So metastatic samples taken prior to treatment
Yes.
of TDXD. Okay, so there was probably heterogeneity in those samples as well.
Absolutely. Yes.
Yeah. And did you have serial samples?
Did I have what sample? Sorry.
Samples taken after resistance?
Not in the study. We are working to try to apply to receive patient samples over the course of treatment for future studies.
TDXD resistance is very important, obviously. Okay, do we have any other? No? I guess I can keep going. So, Dr. Kurisetty?
Yes.
Yes, with your study. From memory, you used the GEM model, didn't you? For your, did you use a mouse model, the HER2 mouse model, to study HER2 resistance? Yes?
Actually, we are using the GEM model to understand the heterogeneity, HER2 heterogeneity. And we're using a DOX-inducible system, that especially diet, at different dosage levels to see how the heterogeneity varies. And we wanted to use 3 different doses, and then we wanted to also switch off the DOX-inducible diet after preliminary 2 weeks of diet. And then we wanted to see whether that actually changes. And then when we reintroduce the DOX-inducible diet, whether the tumors are going to grow and then show particularly different heterogeneity. And we wanted to extract the tumors and then look at the tissue markers, and as well as LARS2 and HEX2 expression also.
And what are your next steps? Will you use another model to try and validate that?
We're also planning to use xenograft models later in the studies. But at this point of time, we are just using the DOX-inducible diet to see the heterogeneity at this point of time. Once we see tumors, and we wanted to use specifically xenograft models to study how this marker changes over time, and whether that also relates to the residual disease, because that particular study has already been reported that the residual disease in patients, their cell cycle dynamics is similar to mouse models also. So, yeah.
Well, I have one question to you all. I think that from the preclinical perspective, the data were very, very solid. I think that, LARS, XB, CD155, everything was. So do you have any comments about how to move forward now? How are you going to translate the data you have into a clinic? Or have you talked to any companies to do something in the clinical? So how to move forward from now?
I have a disclaimer for that first. Okay. We just started.
If you can. If not.
Yeah, we just started, and then we are actually developing the lab itself from an empty shell into a functional lab. And apart from that, we are also using certain technologies and methodologies to understand how this residual disease progresses whenever there is HER2 neoadjuvant therapies switched off. So we wanted to use that. I mean, what you said is actually great, in a sense, like we wanted to see it over the time, because the tumor generation itself takes about 3 to 4 months and different doses. So we are also using 10 times more dosage also to see whether tumors are developed much earlier than what is expected of. So, and clinical studies is, I think, a bit further away. So.
And one other question. So I have used HER2, and I'm using HER2-DX in the clinical practice for some patients, to be very honest. Do you think that it is the time to start thinking about using TNBC-DX in the clinical practice as well, or do you think that we need more data?
So we just published the results, including neopac validation of TNBC-DX in Annals just a couple of months ago. I think it's incredibly convincing. I'll also give the disclaimer that I'm a radiation oncologist, not a medical oncologist, and so I'm not going to be the one making those decisions. But I think, like HER2-DX, it's very compelling that this is a very prognostically useful test. Hopefully, in time, we can figure out that maybe it's predictive as well for specific therapeutics, and we can use that to tailor treatment for individual patients.
Thank you. I mean, there's one question on the chat about how we should be incorporating TIL and other immune markers into breast cancer treatment. I'd encourage you to come to the state-of-the-art session at 2 p.m. today. For that, there's a whole session on immune biomarker incorporation. So with that, I'd like to thank everyone for being here. I'd like to congratulate and thank the poster presentations, and thank you to Dr. Cortés. Thank you all.